Hello and welcome. I'm Rachel Krug, the CEO of Virtual Field. Virtual Field offers an exceptional eye exam experience with visual field, color vision, and pupillometry exams in a comfortable, patient-friendly headset. We run a webinar series that's focused on patient experience, diagnosis and monitoring, practice evolution, and contribution to the profession. And I am honored to be joined today by Dr. Sismanis on the topic of how oculoplastics use the visual field exam. Dr. Sismanis, could you briefly introduce yourself, please?
Sure. My name is Jimmy Sismanis. I am an oculoplastic surgeon in Richmond, Virginia. I have like essentially a hybrid practice. I own my own practice, and I'm also affiliated with the local university in VA. And I've been here for just about 9 years now.
That's awesome. Thanks for that. So let's jump into a couple questions. And if anybody has questions they would like answered, feel free to put them in the Q&A and we will respond. But our first one is, can you explain why a visual field exam is essential in oculoplastics?
Yeah, so I think there's two big reasons that as oculoplastic surgeons we looked, at least I look to a visual field. And I think one is for insurance purposes. uh, for a lot of the eyelid surgeries that we do for visual field improvement, which are things like, blepharoplasty, ptosis surgery, and surgery to address brow ptosis, the onus is on us to prove to insurance that there is a visual field problem and it will improve with addressing the issue. So visual field from an insurance perspective is critical, and having a kind of a clear report of that is also just makes life so much easier. So there's that. And then, I think a lot of the things that we see that involve the orbit, the eye socket, trauma, tumors, those sorts of things, I think it gives us a good assessment of optic nerve function. So I think those are the two key points. And I think I'll throw in a third actually, which is, I think, tied to the first one. So when people come in with visual field complaints, or they say, my lids are droopy, I'm not sure what I want to do. I mean, yes, we want to prove it to the insurance company, but we also want to prove it to ourselves and to the patient. And I think from the patient perspective, it's not infrequently that I hear once I come into the room, one of the first things I say is, hey, how'd the visual field go? What do you think? And most of them are just floored at how many more times they were clicking with their tape field. So I think showing the patient what they're missing, because this is a gradual process. I think sometimes it's an abrupt realization for them, and it kind of helps them grasp what we're trying to achieve. So I think those top three things are kind of why I turn to a field of vision test in my practice.
That's super helpful. And how is it different than other types of eye exams you might be running in what it is assessing for you?
So, I mean, we're pretty at least in my practice, but I think most oculoplastic surgeons are reasonably low tech in terms of examination. A lot of it is just physical exam. We don't rely on OCTs or other technology. At least I do not, or very rarely do I rely on that. Other than my physical exam, I really do rely on the visual field every day to assess kind of improvement or potential to improve. Like, let's say you have a patient with glaucoma and ptosis, I tell them up front, listen, your visual field may be limited. Ptosis surgery may not actually help you, but let's do a taped and untaped field. And I think that will convince everyone, yourself, myself, insurance, that this is either a worthwhile endeavor or it is not. So I think in that aspect, it is it's unique for me in that. And like I said, testing the optic nerve function, other than looking at it, sometimes the optic nerve can appear normal, but there is damage being done. So it truly is like, I mean, that's the only other test that I rely on for this sort of stuff, other than, like, I guess, imaging, like CAT scans, which I can't do in my office. So to me, it's a critical part of my exam for the vast majority of patients.
Thank you for sharing that. Could you share a specific patient case or a couple cases where the visual field exam significantly impacted the treatment plan?
Yeah, I mean, other than like pretty much every eyelid patient, like upper lid patient that I see, I mean, this is a story that I've told many people, but I think like for me, where it really shines is you have a patient who is acutely losing vision. Let's say I had a thyroid patient who came in, her field of immediately we had gotten scans. They were pretty impressive. It looked like the optic nerve was being compressed. It's a bilateral process, so you're not going to see an APD. Her nerve at that point looked healthy, but I mean that's only a matter of time before that changes. And so we did a field of vision test. Clearly constricted visual fields. We admitted her to the hospital, put her on steroids, and every day I brought the virtual field in and an iPad, and I ran fields on her day to day as she was getting her steroids, and we could see her improvement in visual field. So, I mean, for me, that case alone, like being able to take this into the hospital and track a patient, knowing she was safe for discharge, knowing that what I was doing was actually making a difference, and that she didn't need like urgent surgery. I think for me that kind of speaks volumes. But that's just like one example. I mean, it's not often that I do have to haul it into the hospital. We have many patients with thyroid eye, and it definitely helps direct me in terms of how acute they are. So the first visit that I have with a patient, other than a physical exam, dilated exam, they get a visual field as well, so I can kind of check up on things because those sorts of issues can sneak up on you.
Right. Right. That's a great case, a great example. And you've mentioned how this can impact patient treatment plans. How do you effectively communicate the results of a visual field exam? You mentioned taped and untaped and showing the difference. Are there any other ways that you communicate the results to patients? And what strategies do you use to ensure that patients understand their results?
Yeah. Well, that's a good question. So I think partly I let them communicate to me, right? I asked them, I'm like, how do you feel about that? What did you think? At least for the taped and untaped fields. And they usually communicate it to me. They know. I don't have to say anything. They could tell. But again, the reports are pretty easy to comprehend, which I think is important for patient. You could show them, hey, look at all this stuff that you missed, or hey, this is a completely clear field of vision. It's also important for insurance companies too, and you often have people who are not your peers reviewing these, and it is like the layperson can understand the reports. So I think that just the interface and the way the reports are printed out, which I've talked to you guys a lot about in the past. I think it is easily understood by a broad range of people, which is very important. So I think to me it's asking the patient how they feel about it. Honestly, with like ptosis patients and stuff, there's not a lot of discussion because they know.
Yeah.
And then other patients, it's either, hey, yeah, your field look great, or I can show them like, look, you're looking through a pinhole, and they can clearly see that.
Yeah. Awesome. We have a couple questions from our attendees. Thank you. Attendees will answer these live. And if you do have a question, again, please put it in the Q&A. But the first one is, given that visual field exams are often part of the preoperative assessment, how do you manage cases where the results might contradict surgery or where they highlight a risk that wasn't previously considered?
Okay, so I'm guessing by contradict surgery,
Sorry,
it's
it
let's
says contraindicate surgery.
Oh, contraindications. Yeah. So I think it is, like you're saying that the patient, you look at the patient, they look like they have ptosis that is visually significant, but you do a field of vision test that doesn't qualify them.
Yeah.
We do see it some. I think part of that is before you put the headset on, you talk to the patient, and I've kind of trained my staff, and I will also tell them because I'll pop in before we do the field of vision. I'll look at them. I'll say, "Hey, what's going on? Are your eyelids bothering you?" And they'll say yes. I'll say, "Well, okay. Before we do our full exam, I'm gonna order a field of vision test. Let's kind of see how you do with that." I tell them routinely, in our day to day when our lids are droopy, we try to compensate with our forehead. We really work hard. That's not a sustainable thing. And so I would say just try to relax and give me an honest test. we don't want you cranking your forehead up and looking around. I tell them also, I mean, you have to give me an honest test. You can't just not click. That also is not, and sometimes patients will come in with minimal skin and they just squint when you take photos. They don't click when they take a field. That doesn't fly either. And I find the vast majority of patients, they do fine. Now, sometimes we do have to repeat the test. So I'll give a patient a couple tries. If they can't perform at that point, I mean, I will not do surgery without a qualifying field. I just won't do it, but I will give them another opportunity. We sometimes will bring them. I'm only in the office 2 or maybe 3 days out of the week, so we'll just bring them in on a day where I'm not in the office, and with my techs, they'll run it through it a few times when they're relaxed and not anxious, and that will qualify it.
Right.
So I hope that answers that question. Well, the other part of the question was what?
So there's actually a very similar second question. How do you handle cases where the visual field results are borderline or ambiguous? So very similar question from another member of the audience. Do you have a protocol for when to repeat or refer the patient for additional imaging?
Yeah, well, I mean, so for basic ptosis, I don't need imaging, but I mean, otherwise, yeah, I mean, I guess there's rare instances where I'm just looking at them and I'm like, I'm just scratching my head. But again, I think usually we could get them to qualify. I tell folks it's like riding a bike, so there's a bit of a learning curve and patients don't want to fail. So I think a lot of times they'll look around. I mean, we catch that with the gaze tracker. The test itself does redirect them though, and I mean, that's one of the beauties of the device, that like my staff don't sit in the room. They're sitting there at the desk. I mean, sometimes they'll look at me and they'll be like, oh, that lady's clicking way too much. That guy, and so sometimes we'll even stop it and go in and talk to them a bit before we run the whole test, because you can tell they're just looking around. But again, I truly believe that you look at a patient, you have the clinical findings, the visual field is going to support that. There's instances where we can't get them qualified, not because of their untaped fields, but their tape fields don't show adequate improvement. And then I worry, yeah, maybe something's wrong with their optic nerve. And if I can't explain it, yes, then maybe I'll talk to their eye doctor.
Mhm.
If they don't have an eye doctor, I'll get them plugged in for a complete eye exam. And then if we have any doubts, yeah, sure, I ordered a ton of CAT scans. I do favor, at least for a preliminary test, CAT scans over MRIs, which is probably outside the scope of this. But yeah, sometimes I will get imaging, but that's usually patients who come in with something leading me in that direction. We've got a 30-2. We're not doing just the superior field of vision. And that has led me to check imaging. Um, I hope that answers the question.
Yeah, great. And again, attendees, feel free to ask any additional questions. Um, One question that occurred to me from this conversation is there any difference in how you approach a patient that has a more complex history? Maybe they've had a previous surgery, or some kind of trauma?
I mean, I think it just depends on the context, but when it comes to like functional eyelid surgery or surgery to improve field of vision, the history doesn't matter. And sometimes patients worry about it, like, I've had a blepharoplasty before, it doesn't matter. The
Yeah.
criteria are cut and dry. There's like very little gray. Now, I mean, sometimes when you look at the Medicare criteria, which most insurance companies abide by, there is a little ambiguity in how photography has to be like presented and stuff. But when it comes to visual field, it's pretty cut and dry. It is pretty cut and dry.
Cool.
And it's sometimes eyelid problems. They're like, okay, they have ptosis, but they have an upper lid entropy. And so if they have that, or they have like a lot of excess skin and upper lid entropion, then perhaps I don't even do a field of vision test. It's an upper lid entropion, and it's called a bleph repair of entropion. There's a code for that. So, I mean, I think the context matters. But no, if someone's had a blepharoplasty before and they have ptosis surgery, then the test is the test, and there's no in between, right?
Yeah.
And that's insurance. The criteria are very cut and dry, and we have to abide by them, and it's our responsibility to do that. And of course, people operate in the gray, but I do not. I try not to.
Yep, fair enough. And so you've mentioned using the virtual fields a couple times. Thank you for that. Um, what else what else about virtual field has helped you? What change has that brought to your practice?
Oh yeah. So, I mean, I think at least people in our field, a lot of my colleagues, we do travel a bit to see patients. We're very niche specialists. There's not a lot of us. And so, a lot of us do satellites. And so for me, I'm out of my hometown once a week seeing patients. Um, and prior to, and I don't know when I got the virtual field. I think I got it pretty early on. I've been using it for a while. I was trying to think back. Like, does 2020 sound right?
Yes.
2019, 2020,
Yes.
something like that. So for me, it was a game changer. And like prior, I always thought about a larger format perimeter, but they were costly and even looking at them used. And then it's like, ah, man, I mean, we run a pretty lean practice. Did I really want to dedicate a room to that and the staff to that? And then what about my satellite patients? And we were doing a lot of tangent screens, and that didn't feel quite right. I mean, and I know a lot of people probably still are, and then I'm like, I know there's some, I've heard of a virtual reality, like visual field tester. I mean, that sounds awesome. I mean, maybe it's outside of my price range, but I looked it up, and it was like, I mean, within using it a few times, it's paid as expense, and it is a recurring fee, sure, but my staff, they don't care about the stuff I pay for it, the laptops, the whatever, they don't treat it like it's their own. And I'm fortunate, it's actually a pretty robust machine, but we've had our little clicker replaced a few times. It was like overnighted. The
Yep.
headset now we've replaced once at no additional expense. So
Right.
I'll pay the monthly fee. I don't care. It is easy. It is portable. It doesn't cost me much. The patients actually are like, sometimes they ask me, well, why isn't my doctor using this? Or, it's like, this is a lot easier. This is more comfortable. I mean, some see the larger format devices and they think it's better, but whatever. It is pretty rare that we get pushback, and it has made my life profoundly easier. And in terms of auths, like, it's kind of dummy proof, man. It gives you a nice printout. It gives you the like the percentages very clearly. So I don't remember the last time I've done a peer-to-peer on blephs or ptosis. I mean, granted, I am pretty like, I'm not keen on doing them, and my staff know that, but I don't remember the last time we've had a denial either, like where like we couldn't auth the patient, where I said, no, this qualifies.
Right.
It is short of like the insurance company saying this is not a covered benefit. They don't push back when we submit the fields. They're very compelling.
Right. Great. Thank you. Thank you for that. And then last question from me, how would you recommend integrating visual field exams into a multidisciplinary approach to patient care?
Yeah. I think it depends on what you mean by multidisciplinary. Like in my practice, we do a lot of skull-based surgery, and complex facial surgery, where it's like, oh, there's a tumor in the nose and extending into the eye socket, or coming from the brain and into the eye socket. And then they rely on me to tell them how the optic nerve is doing,
Mhm.
right? So from a multidisciplinary approach like that, well, it's my job. If I see a tumor in the eye socket, I look at the imaging. I maybe order more imaging, and I do the field of vision test, and I do it progressively. And the key is beforehand and afterwards as well, because everything we do could compromise the optic nerve, right? So it's for liability, to protect us, to document any pre-existing deficits, and to show that we didn't cause worse ones, and for the patient's sake, because sometimes we do, and it's like it's important to acknowledge that, and then we track it, and a lot of times it gets better. So from that perspective, now from a multi-specialty group, like multiple like ophthalmologists,
Yes.
I mean, I feel like all of them are going to benefit from it, and one machine is probably not going to be enough. But again, like, I don't know how many fields we do in a day. I see about probably 20 new patients in a day, 25. And I would say like probably 70% of them at least need field. So me alone, like some days I'm like, if they're all like eyelid patients, sometimes that happens. We get really behind because we only have one field. And I feel like, gosh, I really could get a second headset. In a multi-specialty group, I mean, you're gonna need. I mean, we had one talk because I've done one previous talk. The glaucoma guy, I think, had several headsets just for himself.
Right.
But like every ophthalmologist or optometrist, I think any practice is going to use rely on some visual field testing, probably reasonably heavily, I would think.
Yep.
So you
Yeah.
guys might fight over it, is I guess what I'm saying.
I love that. Well, thank you so much for your time, Dr. Sismanis. This was very informative. And thanks to everybody who attended. It's nice to see you. We will see you next time.
Thank you for having me.